Every leader has a strategy. Executing on that strategy is the challenge. If you want to learn how to effectively achieve what you've set out to accomplish, then this show is for you. Gain keen insights and listen in as leaders share their stories and challenges. SOAR Vision Group and the Baldrige Foundation welcome you to Leader Dialogue Radio.
Hello, everyone, and welcome to Leader Dialogue, brought to you by SOAR Vision Group and the Baldrige Foundation. I'm Duffie Dixon. Joining me is Jennifer Strahan. She is the Chief Operating Officer of SOAR Vision Group. Jennifer has partnered with more than 100 health systems and businesses across the U.S. She helps them transform their strategic and their administrative operations. Absent this week is CEO Ben Sawyer, who we always tease, Jennifer, that he's always doing something fun. Where is he now?
He's actually off in a really neat retreat for a nonprofit organization, and he's supporting them as a guest to their strategy. So he's
working
fun.
this
Still
time.
playing golf.
It's mostly play, but he gets to throw
he's
in some
playing
really
golf.
cool stuff. You know, when you throw golf into it, it makes work a little bit easier.
Yeah, that third voice you hear is a new member to the team. This is Lisa Counsell. She is the new Chief Commercial Officer of SOAR Vision Group, and you have a long career in nursing, primarily in critical care, and so that really brings a great perspective to the table of people who see patients, deal with doctors and administration. You get to deal with it all. I have a friend who's training to be a nurse right now, and she is so excited, and I think, oh, you've got a big job ahead of you. So congratulations. Thanks for joining the team.
Yeah, you bet. Thanks for having me.
Now, this is the section that we call a deep dive, okay? Because we're following up on what we talked about last week, and primarily who we talked to last week. That was Bob Peterson. He's the CEO of Millinocket Regional Hospital in Maine. This is a smaller school. It's considered a critical access hospital. And what that means is there are 25 or fewer beds. The length of stay is about 96 hours, and they offer acute care, but it is not just emergency room, right, Jennifer? This is a small rural hospital that is needed.
Right. So they offer, for the most part, full set of services across the board, which creates a very unique niche in their community, because their closest hospital is 40 miles away, and their next closest tertiary hospital for those very advanced cases is 75 miles away. So that's a unique role that they can bring, and just a significant value to their residents.
And without them, oftentimes patients will die in transport from their community to those larger facilities.
Yeah, he talked about heart attacks and strokes, and we just had cardiac surgeons on the show, and on another show I was on, and they talked about every minute counts. And then they talked about things like snowmobiling accidents, and I thought, it's Maine. When you could get snowed in, you can't have a helicopter fly in a snowstorm. So these are really critical. That's the reason they're called that, critical access hospitals. He also had a really unique, I mean, he's just a great CEO. I mean, don't you get that?
Yeah.
Why? Why is he a great CEO, Jennifer?
So I've been fortunate to get to know Bob on a personal level, because we're doing our doctorate program together. And so we've gotten to connect, and also even connect from the perspective of business, and talk about, obviously, hospitals and healthcare. And it is, his passion just shines through in everything he says, whether it's from his 3 grandbabies, which are very cute because I've been able to see their pictures, or if it is from work. And, you know, one of the things he mentioned was he loves going to work every day. And I think that passion is what really creates excitement in leadership, and to maintain that throughout a career, because he's had a very successful career, that really speaks volumes to him.
And he says he's really happy that, he calls it the last part of his career, he's really happy that he is in this rural setting. And he talked about some of the challenges and some of the successes of being in that rural setting. Can you highlight some of those?
Sure. So as a reminder to our audience, some of the things that they're talking about, you know, from a critical access hospital, you have a significant barrier when you're working with volumes of patients, your payer mix, in terms of, are we getting paid? Do we make enough money to cover our bills? Because it's a very different structure than those large hospitals who are in urban areas. And on top of that, of course, you just have community challenges that you're dealing with. It does make a difference in terms of the employees that you have and the types of specialties that you can bring in. So there's just a very different approach to strategy that these smaller rural hospitals have to focus on. And I would just say that's not really just hospitals. hospitals. I mean, that's across the board for rural America, and even to tap into small businesses that are competing in a very large market, you have to find ways to differentiate yourself. And one of the things that I loved is that they have differentiated themselves by making sure that everybody is family. And that's something we say often, treat everybody like family, but they have a track record for doing it. And he could tell you story after story. And you probably recall the really great story he shared, gave me goosebumps when he was talking about the individual who one of his last requests was actually to play a piano. And his doctor went out of his way, went home to get their piano and let him play and just highlight that for him. So what a great story.
Super cool. I'll say that on the payer mix side, in rural communities, oftentimes they're Medicare, Medicaid patients, which again are completely out of his control.
Right.
If there were large industries or there was someone who came into the market from a business perspective, then there would be more access to commercial payers. His payer mix would go up.
Right.
So he really is only playing in the sandbox that he can really control anything, because the payer mix is not something other than lobbying his legislatures. How do we actually change that reimbursement rate? So I applaud him for really going after culture, because he needs to make that organization, and he's doing it, one that everybody wants to come to. They'll even drive extra to go to him.
Yes. So one of the quotes that Ben will often mention, so since he's not here, I feel like it's our obligation to highlight him. One of the things that he'll often say is that, every leader casts a shadow, and that an organization lives in the shadow of the leader. And what a great shadow to cast from Bob. When you think about the culture he's been able to create, that's a unique thing. And some people will say it's easier in smaller hospitals than larger, but I actually don't know if that's true. I think that there's less people, so once you start to create it, it spreads a little faster. But, culture is one of those things, it's hard to change anywhere.
Absolutely. And I think you still have a sphere of influence that become those 10 or 20 people, and he's got well advanced to that number. So I think he's really tapped into something that his shadow is really making an impact in a community long term. Yeah,
and I love that, because when we think about leadership, it's a great legacy for leaders. Yep. What's the legacy that our leaders are leaving? And so we ended the show, he brought the challenge out to say, hey, I want all of our leaders, my challenge to you is to go talk to patients, get out of your chair, leave the spreadsheets and the different reports and data and everything else that you're looking at behind you, and just go talk to patients. So talk about that a little bit, Lisa.
Yeah, so I'd say that the healthcare industry really is making a big push globally to do rounding to influence, is what it's kind of labeled. Bob's probably been doing this for a very long time, getting out, and he was at much larger organizations before. So Eastern Maine Medical Center was a large organization that he worked at before. So he's seen the big, and now he can appreciate what the rural hospital, the differences and what he can bring to bear. But I applaud all executives in healthcare today. If they're getting away from their desk and they're actually getting out to patients and interacting with families and really connecting on that human side, and not just being tied to what's my reimbursement rate, what's my length of stay, what are my ongoing challenges from an economic standpoint, and really making it more human, as Bob called it. That it should be a human business.
Right. You know what I love about that is that when we're looking at reports as senior leaders, and you're looking at things such as our readmission rates for patients that maybe should not have been back, or patients that should have, when we're looking at things like our hospital-acquired infections and the different things that help us manage our business, we see numbers all the time, right? We see rates, we see data. But when you're out and about, those numbers are not just numbers anymore, they're faces. And that's so much more powerful when you start to change that culture. And even think about like high reliability organizations, that has an impact there.
And Lisa, being an employee, as a nurse, when you deal with your administrators, what does that mean for employees when you see the leader get in there, get in the trenches, talk to people, and talk to the employees, as you said, talk to the patients and their families?
Yeah, absolutely. So, and I've been out of nursing for a while. I moved on to the kind of clinical informatics side of it. But even in the days in the trenches, when I had a boss who was willing to do everything he or she expected me to do, you're willing to go above and beyond, right? And I think that's true with any business. If your leader is willing to walk through the wall of fire with you, you're gonna step up and do the exact same thing. I think that from a healthcare perspective, Employee engagement is, again, kind of a coined term that's gotten some roots lately, and people are really trying to engage at the front line, because if you don't empower the people at the front line, you're not going to make change, regardless of the size of the hospital. So again, having even employees see a CEO in a hospital, make rounds, talk to family, that's a pretty big change and a big shift from years ago when I was clinically practicing. So again, I think that the more that people are really working together and collaboratively on either the employee engagement or the patient engagement, it really is making a difference. And statistically, it's proven it.
So let's pull this back to the hierarchy of needs, just for our listeners, to make sure we're connecting the dots, because we've talked about a few things, and one of which is around colleague engagement, which really is the foundation of our hierarchy, right? Because if our colleagues are not engaged, they're not going to want to deliver care or deliver their service, because again, that's relevant beyond just healthcare.
Right.
And if we can keep them engaged by helping them do their jobs more effectively, more efficiently, helping them not have to work excessive overtime and not having to constantly fight the battles that really are not necessary, I think that tends to drive a lot more value that we can bring to customers. And a big piece of that is supported through leadership. Because if you remember, leadership kind of crosses the angle across all the different aspects of the hierarchy. And what that does is it empowers your employees to do things like go out and get a piano to let your employees play, right? That's unique, again.
Yeah, and I wanted to ask, how free do employees feel to do things like that, to think outside the box, to we've had examples, and I've been wanting to ask you about this, Lisa. There are some times that they will let people bring in their dogs for a last
pet
visit. Pet therapy, and that's something that, it used to be one visitor in the room, there will not be any animals. Yeah. But that sort of thinking to what will make the patient have those last experiences the best. Who has to say it's okay to think that way? Or, I mean, you have to get direction, right?
For sure. And I think leaders in hospitals are seeing, from a patient experience perspective, they're hiring patient experience officers. I'm excited that many of those people are not clinical in nature. They're coming to the organizations like Cleveland Clinic as an example, and they may have been a patient, who may be in remission for cancer, and they have a different perspective on what patient experience is. So I do believe that organizations are really allowing certain people inside the organization some latitude to go outside the box. And again, if employee engagement is really top of mind, they're letting their employees come to them and say, hey, I think it would be great if we brought in a keyboard for a patient as kind of their dying wish, or I bring in a pet from a pet therapy perspective. So I still don't want it to kind of hit on one or two people's, their responsibility, but it should be a culture. We're still back to a culture of engagement.
Yeah, which is driven by leadership.
Right. And some people are going to say, well, we can't have anything that costs money. Okay, bringing in your own keyboard doesn't cost money. Therapy groups work for free. Yeah. So those are just little things that make a huge difference to frontline workers.
Well, and there have been studies, I believe, that I'd have to go back and give you specific reference, but it'll show things like different creative therapies and things that make patients happy. It shortens their length of stay and it shortens their recovery time. So it's actually a value to the patients, not just for us to make them happy, but for them to actually get to experience that and then be able to get healthier faster.
Yeah, and Jennifer, you touched on something a little earlier in the dialogue, and that was really around kind of the employee side, which clinicians often have great burnout in healthcare. Yeah. And so whatever we can do, again, to have a success factor for them and really do something that's unique, that improves, statistically, that improves their the lack of burnout and reduces their burnout rates, which is a really concern among healthcare providers today.
Right. And that's across physicians, nurses, across the board. And so how do we engage them? How do we encourage them? And again, empowerment for them to be able to come up with creative ideas and not just say no because it's different, which is important.
Or we've never done that before.
Yeah. Like we can't do that. Well, why not? Well, I don't know. It just doesn't make sense.
Because Jennifer, we've never done that before. It's never been done that way.
Yeah, exactly.
Our favorite phrase.
Yes. Yes, or that didn't work. We tried that before. That's another good one. So if we think about this in terms of, again, kind of relating that to the hierarchy, and the colleague engagement supports that strategy, and that's been a way that he's been able to differentiate himself. The thing that I really like about that is sometimes when we have small businesses, the community and patients or customers will often say, well, that's the only place we have to go. But they've worked very hard to actually not have that happen, where this isn't where you have to go because it's the only option. It's where people want to go.
Yeah, I mean, he said they could drive 35 miles to the next facility. 35 miles is nothing. I mean, it's
maybe not in Atlanta, but
maybe not in Atlanta, but still, I mean, it people have choices,
yes,
right?
Exactly.
Telemedicine is now very big. I think, again, people like that human side to healthcare.
Yes.
That's kind of an expectation.
So one of the things, just tie in what you just said about the human side of healthcare and back to what you mentioned about burnout. A lot of that, I would imagine, and I'd love to hear your thoughts on this, even though it's been a while since you've been kind of on the front line. We're still seeing it. You connect with nurses and physicians every day. But thinking about how we get so caught up in doing every single little task of what we have to just check off of our list for the day that we lose track of even being able to have that human side, because we've got to document this or we've got to do this thing according to this policy. And I think we lose time to innovate.
For sure. And I would say, I kind of was fortunate to see the whole movement of the EHRs when we automated healthcare documentation. And I was old school, where we were charting, everything manually, and I was master task list. Man, I was good at checking off a box. But there is something to be said. Those tasks have to be completed, but then you get even more removed when you've got a distraction of a computer system or a barcode system, and there are distractions and even medical errors that you're intentionally trying to prevent with those systems often they're exacerbated because of the distraction. So I'd say that, again, it takes a real initiative on the part of the clinician to really say, okay, I'm gonna give you quality time, and I'm gonna really focus on you and not be distracted with all the things that they say that on average nurses are distracted every 2.5 minutes.
Whoa.
How do you get anything done?
It's like a toddler.
That's right. Seriously. Yeah. So somebody's needing you to do something. Somebody's calling your your pager. You're getting buzzed overhead because there's a family member. And back in my day, we didn't even have 24-hour visitation. Now hospitals, that is part of their customer service. Even in critical care, my background, we had 4 times a day for 15 minutes, and they had to come and go. Not true anymore. These family members can come anytime. High distraction environment. So to really be able to offer some dedicated time and focus for their patients is very difficult.
So you bring up a really good point, because what that creates is a little bit of a struggle between customer value, because patients want to see family want to see patients, and organizational effectiveness, because you've got to have some guidelines to say, when do we make sure that we're not hurting one versus the other. And another thing that I think comes to mind with that is the challenge of making sure that when we create new process, when we create new technology, how do we do it in a way that is actually encouraging and supporting the process in the way it should go, versus adding steps to a process, right? Because a lot of these things, when you think about electronic medical records and different systems we're using, there's good reason that we have them. It adds value because we can document
safety
things.
nets.
Safety, yes, it catches things that we wouldn't have otherwise. But there's a flip side and a trade-off to that around how do we make sure we're also not creating new distractions with that.
Yeah, when you go into the doctor's office and everyone's looking at the
computer,
screen.
yes.
I'm looking at you. I had a really
I'm talking to the back of your head.
I know. I had a really wise instructor when I was in nursing school who just said, look at the patient. Like, again, with monitors and critical care was my background, but even if you're just on the med surge, everybody kind of gets caught up in the telemetry and what do the monitors say? Look at the patients. Like, there's
it means so much.
Right. Be in the moment, right? Absent present, as I give my husband a really hard time. Like, he's in the room, but he's really absent from this conversation.
When you've been in the room together for 15 minutes, you're both looking at your phones, you realize you haven't communicated face to face when you're sitting on the same couch.
Yeah, exactly.
And we do that in
Business.
healthcare.
Yeah. Well, in any business.
But even
Yeah.
more dangerous in healthcare, right?
Yeah.
Right.
Because it can be the difference between life and death. And I love that systems can help prevent medical errors, and that's their driving intent. But at the same time, there's a lot of distractions, as
Yeah.
you said, Jennifer. It's not augmenting the process. Oftentimes, it's layering onto the process to an already stressed and
Right.
overworked workforce.
Well, and I think what this has done, though, is it's created a window for unique businesses or unorthodox businesses such as Amazon or other areas to come in that may have not been considered a traditional person in that industry, and that's where your disruptors come in.
Yeah,
and
that's
so
for sure.
I think the midst of all this technology has actually allowed us to start to see, there's an opportunity there, because historically, and I think we still have a long ways to go, healthcare has always been, you have to really peek behind the curtain to see what's going on. You don't actually always see all of the busyness, the hustle and bustle of what's going on to treat a patient. There's a lot of stuff behind the scenes. And so how do we create that transparency? How do we take that away from the mystery of it, right? How do we take that away from healthcare?
Again, technology is important.
Yeah.
I do think Amazon is a great example of a disruptor, and they're going to come in and say, okay, we don't have any preconceived notions or expectations, and let's do things differently. So, I'm intrigued to kind of find out what they're going to do. At the end of the day, it still kind of comes down to Bob's environment, where it's people delivering human health care to their patients.
Right.
Whether you're, in a 25-bed hospital and you're yelling down the hall because you want a CBC stat, or you've got an electronic medical record where you can do it, quickly and efficiently through a computer. At the end of the day, you still have to get to the human nature of the business.
Right. And I think that's one of the things that continues to create the strategic differentiation of it. So one other thing, just to kind of pivot, because I want to bring up another topic that he talked about, which was around consolidation in the industry.
I was going to ask you the same exact thing. So can I ask?
Yeah,
this may
okay.
We're all hearing about bigger hospital chains
Yes.
buying out smaller ones. Does that mean they're eliminating them, or could they allow those smaller hospitals to still operate under their framework? And if they do they have the capacity to allow that old school medicine style of treating patients work in those rural areas? I mean, that's like two worlds colliding.
Right. So there's a couple of approaches in which you typically see that, right? So one is that you do hear a lot about that, and a lot of this started especially with the ACA coming up from all of the 2009 with all of the regulations that were changing, because hospitals recognized that our payment structure is changing, right? So we're going from, although we say, or that was the intention, to go from volume-based to value-based and being paid based on value, not just
Versus
how much,
fee.
right? Not just how much service or how many tests I can give you, or et cetera, even if you didn't need it, right? So that was kind of the premise behind it. We still, again, have actually a long ways to go in that world. But in the midst of that, it was the sake of how do we create efficiencies, and one of those was how do we create more buying power coming together with consolidation, maximize things through our supply chain and different factors that can help us just run more efficiently. So for some organizations, when they were buying up these smaller areas, it actually helps the big organizations, because they can divert the patients who probably don't need to come to their facility.
It's a good triage mechanism.
Exactly. They're bursting at the seams. We have a lot of needs in hospitals, and we don't always have capacity for them. So by supporting those organizations, they can actually maintain their business. So they can subsidize some of them because of their challenges, and it actually supports the larger organizations. But that doesn't always happen. I know, Lisa, and I'd love to hear if you've had an experience where there are times when they actually don't keep the hospital open.
Yeah, so, again, we've all seen consolidation. The big boys in Atlanta, they're reaching further and further out into rural Georgia, and they're aligning with organizations they're either partnering with. Usually that's how it starts. I partner with, and then I buy, or I partner and I merge, whatever the term is.
The big joke is partnering means merging. Yeah. Let's just say it.
For sure. But again, we heard Bob talk about the financial constraints he's under. That's a huge challenge for his organization. So having a large mothership that actually has a better payer mix that can help offset some of those service line costs that Jennifer mentioned is a really big value to them. The downside is oftentimes they'll partner, they'll date you for a while, maybe they'll even buy you and marry you, and then they may still close you down. So I know where I'm from in rural North Carolina, that happened, really small town. The hospital was kind of the lifeblood to my mom and dad, and a larger hospital 25 miles away bought them and decided, nope, we're just going to make you a freestanding ER. It was exactly what Bob talked about.
And what is the what are the downsides from just an ER? Because he touched on that quickly. He said it's not enough for us to be a freestanding ER. What would a freestanding ER look like versus a small hospital?
Yes, so a freestanding ER, your length of stay is less than 24 hours. So we want you in and out. Now, again, there's a lot to be said for the value of stabilizing a patient, getting them to the point they can get into an ambulance or helicopter and travel to the next tertiary care facility. However, that patient may not actually need to travel to the next hospital for surgery, but if they had an acute care bed that they could transfer them into, and maybe it's end of life services, as Bob mentioned for this patient example, it could be a myriad of things that they actually need. But small communities need access to health care. And again, the clock is ticking when you come into an ER. They want you in and out. And again, a lot of that's reimbursement based, but it's also just the sheer nature of their business.
Right. Because it's emergency medicine.
Yeah.
Right. So you're there for emergencies.
Right.
And
I'm triaging the sickest, and I'm gonna make sure that we get them stable. And then beyond that point, oftentimes they may or may not have maybe even a long-term care facility for them to be transitioned to, maybe even into hospice. There may not be those transitional care. What do you do with that patient in the rural America? Then they still have to travel somewhere else or go back home.
Right.
And even think about the impact that has on preventive conditions and chronic conditions, right? How are we managing our diabetes patients? How are we managing our congested heart failure patients? They need that struggle. And when you're 75 miles from the next level up, sometimes, to your point, that stabilizing them is really difficult to do. And then, a transport can actually also be very dangerous for those patients, even if they are stable where they are at that moment. So it's not just about giving them access to emergency care. It's about giving them access to wellness care, which we have not done a good job at in healthcare in the U.S. We're very focused on sick care, not necessarily how do we keep you healthy care.
Yeah, for sure.
Well, and you'll
tertiary care versus primary care.
Right. And you'll notice that a lot of the insurance companies now are trying to focus on wellness. They want you to take steps, the customer or the person to take steps on your part to get those annual exams, to get those tests taken every year, and that's all wellness. And that's great that the insurance companies want you to do that. There's got to be an easy way to go do that.
For sure.
Yeah, so one of the assignments for our class that we did, actually Bob was one of my partners in this, and we got to design healthcare. It was, of course, our utopia of healthcare. And so one of the things we had was, we're just going to make everybody healthy. And then you just get rid of all the issues, right? So how do we just keep everybody healthy? And then we would solve the problem.
Good luck with that.
Piece of cake. I don't
taking
understand
away
what the
all
problem
the
is.
behavioral challenges.
No
taking away
big
all
thing.
The social challenges, other environmental agents. Yeah.
I don't see
Very
the problem.
difficult.
No.
Good luck with that.
Yes.
Why don't you make that your dissertation, your
you
thesis?
said Bob for president, right?
Yeah, I did say Bob for president. He may be crowdsourcing now for his funds.
That's right.
How far along are we? I mean, obviously, we've seen these buy-ups of bigger chains buying up smaller chains. I think we've seen that in all businesses.
Yeah.
There comes a point in other industries, will it happen for healthcare as well, that we'll decide, wait a minute, maybe there's a good balance?
Yeah, I mean, the government tries to regulate. I mean, just recently, Northside and Gwinnett were approved on that merger. And so that financial transaction will happen probably in the summer of this year. It has been in the works for over 3 years.
Yeah, because it's been talked about for a long time.
Right? So the government, had to weigh in. Federal government had to determine, is the CON relevant? Is this appropriate? Again, they're trying to balance out kind of the competitive nature in healthcare. I think more importantly is we really need to be active voters and be aware when it comes down to legislation around healthcare, because if these rural hospitals close their doors, I think it hurts the big guys at the end game, because they need the referral business as well. So more organizations at the larger health system side are seeing, I'm at a disadvantage if I close you down completely, because you are a revenue stream for me, because I can bring you in for surgery or for diabetes care, whatever that may be. So I do believe that there's a shift. Again, every region is different, to collaborate and work with those communities. Again, there's a lot of people living in rural America, a lot in rural Georgia. I think it's probably more than the 20%, I would say, in rural Georgia. And I believe that those organizations have recognized we're not better served if we just shut you down completely.
Right.
I think the end game will be around reimbursements, however. And as Jennifer mentioned, moving from fee-for-service, to this value-based care is not been easy, and we're still kind of in the middle of that move, and healthcare providers and hospital administrators are straddling both worlds. And so I think that the payment structure is really going to dictate kind of the viability of these little hospitals going forward, unless the big boys do what's right, and when they buy them, they don't shut them down.
And we are seeing more creative solutions, because the other thing you'll mention, and you've kind of, I don't know if you guys have noticed, and I was just trying to see if I could find the specific reference, but it's kind of gone a little bit up and down since 2010. We've seen mergers and acquisitions go up, and then we've seen at 1 year where it started to tick down a little bit and coming back up. And so because it's a question of, is it actually giving them the value that they expected from it, from the gains of bargaining power and supply chain and other factors for leverage. But the other piece of it, in terms of, to rural America, is it creates partnerships and alliances. But you'll see some organizations that they may not be able to do actual purchases because of different reasons. So instead, what they are looking at is, what are some of those creative components of creative partnerships. So I want to just put in one plug here, because we've been talking a lot about rural health, and one of the things that we're working on with SOAR Vision Group and the Baldrige Foundation that'll come out this fall, we don't even have the dates yet, we're in the process of it, it's looking like early November, but we are going to host a rural health symposium, which is going to be targeted for not just small rural hospital CEOs, but also larger ones that want to partner with those communities to understand what are some of those creative partnerships, what do they look like. And so we're actually working with some of the hospitals across the country who have been able to do some of those partnerships, to come in as panels and speak, and being able to, again, support what that looks like, because the strategy has to be a little different.
Tell me Bob Peterson is going to be a part of that.
I hope so.
Yeah, we need to get him in on that, because it's fascinating conversation. It's something that, as you said, is not changing, and everyone's straddling both worlds, and we're figuring out as we go along. Another great show, ladies. I appreciate it. I want to thank everyone out there for joining us on Leader Dialogue, brought to you by SOAR Vision Group and the Baldrige Foundation. We will have another live show next Friday at 1 o'clock Eastern Time. And then you can also see we are not TV, we are radio. I'm coming from a TV world. You can listen anytime. We, of course, are on Business Radio X. You can also go to leaderdialogue.com/podcast. On behalf of both of the women with me, Lisa and Jennifer, and also Mike and Trey sitting behind us producing for us, we appreciate you listening. We'll join you next time on Business Radio X.